lecture series. Today we have a presentation by Dr. Balasundaram and Morgan Kowalski. But before we begin with introductions, I want to make sure everyone's aware of the upcoming Stanford Lean Healthcare Academic Conference. It is September, let me see, I think 10th through 12th. And it's an amazing event right on campus. And I highly recommend you attend one or both days if you can. A lot of our leaders make an appearance at the conference. It's also a great networking event. And then the food is wonderful. All the meals are provided if you're a conference attendee. But with that, I can't wait to introduce our two speakers. Dr. Balasundaram is a clinical professor at Stanford University and founder of the Family Center Healthcare Task Force. She serves as the chair of the El Camino Health NICU Family Center Care Committee, where she leads multiple subcommittees. Focused on advancing neonatal quality improvement through direct collaboration with families. In 2022, she founded the International NICU Family Centered Care Task Force and which has grown over to 2,500 global members, including multidisciplinary clinicians and family partners. And then her colleague, Morgan Kowalski, is a program manager of the Family Center Care Task Force and parent of Thomas, a micro preemie born at 25 weeks and 1 day, weighing 1 pound, 11 ounces, who's now a thriving 7-year-old. She uses this journey with her family to inform her work, including advocating for improved family care practices in the NICU. She's the family liaison for the American Academy of Pediatrics Subcommittee on Hospital Care and a member of their Family Partnership Network. And she is a quality improvement consultant, family advisor for the NICU, where her son was an inpatient, and is a part of their Optimizing Neurodevelopment for Infants with Bronchopulmonary Dysplasia project. Welcome to both of you, and I'm very excited to hear about your presentation, A Global Model for Innovative Clinician Family Partnerships in Neonatal Care.
Thank you so much. Good afternoon, everyone. Thank you for inviting me to share my passion. Morgan and I are excited to share our organization's past 3 years journey. It's challenging to convey all of our work in 30 minutes talk. So reach out to us if you have any specific questions. My email is listed here and we will share it in the chat as well. Next slide. There's a poll we put together. So if you can take a moment to answer that poll, and I will let you know the result when I get to that slide. Thank you. So at the end of this presentation, you will learn about the importance of FCC practices in the NICU, the global model of the FCC Task Force, a structure, and how the FCC Task Force utilizes the quality improvement collaborative model to bridge the gap between FCC research and practice. Next slide. Before I delve into more about our work, and I know SMCI as interdisciplinary providers, so I want to know a little bit about our audience. So please take a minute to answer this one question poll. And if you haven't done it already, I will give you a minute. So take the time to answer that, and Selena can close that in a minute. So once we know the result, then I can just understand who our audiences are. Let me quickly recap what we do in the NICU. We take care of any babies who need medical care after birth. Most of the NICU admissions are moderate preterm babies, late preterm, and critically ill term babies. This picture shows the timeline of the pregnancy. You can see less than 28 weekers are extremely preterm birth, and some 28 to 33 preterm birth, and 33 and 34 and 36 are late preterm birth. and anyone about 37 weeks of term. And I intentionally left out the earlier gestational age that we take care of them in the NICU because it keeps changing. In Japan, it's 22 weeks is the limits of viability, and in some centers resuscitate 22 weekers. In US, some start resuscitation at 24 weeks. That's a separate talk about a shared decision making and the periviable period. So I'm not going to get into this. And Selena, if you can launch the results so we can all see. Okay, so it looks like most of you came across the NICU through your professional training, but don't work in the space right now. The next is you heard about the NICU, but don't know much about it. I'm glad to see everyone heard of NICU, so that's great. Okay, thank you for answering that poll. Next slide. So now that I know a bit about you, I'm going to share a little bit about myself. I was born and grew up in a small town in southern India called Kanchipuram, a city known for its thousands temples. And what you see here is one of the temple that built in the 7th century and Common Era. Next slide. My dad owned a small provision store. I think in the US, it's called mom and pop shop. I remember doing schoolwork. Next slide, Morgan. In between attending to the customers. Next slide. I was the first girl in my family to attend college, and that too a medical school with a scholarship. Growing up in a low socioeconomic setting, given me the opportunity to be an empathetic and compassionate caregiver. I'm a minority woman, immigrant woman, and person of color. My journey has been one of overcoming challenges and seizing opportunities to find my passion. Next slide. I joined the Stanford Neonatology Group in 2015 after completing a fellowship in UC San Diego. And all of my family-centered care work and passion started at El Camino Health Level 3 Community NICU, staffed by Stanford faculty. Next slide. Next slide. On October 18th, 2017, my first year on the FCC committee, we held our Family Advisory Council meeting. Imagine a room full of passionate NICU families collaborating with a couple of healthcare professionals. They shared their feedback. Some were positive, some were thought-provoking, some didn't occur to me at all. One mom shared how she felt someone whisked her baby away after delivery, and she wondered for a couple of hours that she had lost her baby and the baby had passed away. One mom shared how she had hopes and dreams about her baby since she found out that she was pregnant, and it all collapsed when we gave statistics about our baby's survival. Did she want to know? Have we asked them? We clinicians show up to work, but the experience could be more different for families. As one parent said here, we are not showing up to work, we are showing up to trauma and fear. Next slide. Hearing so many stories changed how I practice medicine and intentionally engage with families, putting families at ease, reducing anxiety, less pain, and more joy. As mentioned in this NICU parent voice, it's about being human to another human. How do we do this? Only by implementing a family-centered care and following its 4 core components: information sharing, providing dignity and respect to families, and encouraging their participation in infant care and collaboration with families. Next slide. Next slide. I did a quick PubMed search before this talk. We had publications in relation to FCC since 1950s, and an uptick lately close to 2,000 publications per year about FCC and its benefits, but still it's not reaching the bedside. And NICU parents are treated like visitors and not essential team members. Next slide. So how do we know about this not reaching to the bedside? After building the robust local FCC program, I was curious about FCC landscape in other NICUs. So she initiated a national survey of the AAP, American Academy of Pediatrics, TCAN, which is the Trainees and Early Career Neonatologists Cure Interest Group, showed that 65% of respondents did not have committees overseeing the FCC practices in their NICUs. I have listed a few barriers in implementing FCC practices on the left that have been published in literature. So I thought there is an opportunity to combine QI and FCC to bring it to bedside. So I recruited a passionate healthcare professionals and family partners to form this task force in February of 2022. That's the inception story of the FCC task force. Now I will hand it over to Morgan, who will share her story and our organizational structure.
Thank you so much, Malathi. And I apologize in advance. It looks like there's a little bit of a lag when I go to change the next slide. So bear with me. Thank you. Hi, everyone. My name is Morgan Kowalski, and I'm honored to share with you how the FCC Task Force is changing neonatal care to benefit infant health and parental mental health outcomes internationally. Before I get started, I would like to acknowledge my lived experience as a white, Christian, college-educated woman in a two-parent binary household and the privilege I experience because of how I am able to look, think, speak, and act. My privilege had a direct impact on my NICU outcome, and I'm hopeful that with dedicated implementation of family-centered care and considerations for social determinants of health, the needle can be moved in a positive direction for marginalized NICU families. My son Tommy was born at 25 weeks and 1 day, weighing 1 pound 11 ounces, and was inpatient in the NICU for 115 days. Those early days after Thomas was born were utter chaos. I gave birth just hours after I realized my Braxton Hicks contractions were real contractions and was thrust into the world of having a critically ill baby in the NICU. The shame and guilt that I felt for failing to keep my baby safe inside was devastating. He had a long, difficult course and still struggles with vision and hearing impairments, chronic lung disease, kidney injuries, sleep apnea, slow weight gain, and various developmental delays. Health complications aside, he's the most outgoing, hilarious 7-year-old, and to know him is to love him. On day 2 of Tommy's life, our attending neonatologist asked me, "Did his abdomen look like that this morning?" I noticed it was really red around his umbilical line and shared that it hadn't looked like that earlier in the day. A blood test confirmed Tommy had cellulitis, well on its way to sepsis, but we had caught it in time. It was then that this clinician changed the course of my family's care, saying, "Tommy needs you to be his advocate. You and your husband are the only people in this hospital sitting bedside all hours of the day and night. We need you to speak up, ask questions, be here, and help us." Then, when Tommy was about 7 weeks old, I experienced the worst day of my life. While doing skin to skin on the jet ventilator, Tommy had an unplanned extubation and coded. Providers worked on his collapsed lungs for over an hour without success. As they were providing chest compressions on the gray, lifeless body of my child, getting ready to call it, someone insisted on trying intubation just one more time with a fresh breathing tube. Our pregnant respiratory therapist was in and out as x-rays were being taken, and those at the bedside couldn't recall the size he needed. A nurse rushed to her station to work on pulling up Tommy's chart. A nurse practitioner directed someone near the trash to start sifting through to find the old tube to determine the size. Inside of this chaotic moment, I was able to call out, "It's a 3." A size 3 tube was promptly inserted, and Tommy slowly started to recover. As I remember it, family-centered care saved my son's life. What if providers made me leave the room during Tommy's code? What if respiratory therapists hadn't allowed me to be at the bedside when placing the original tube and telling me the size? What if that first attending neonatologist took the 5 minutes where he empowered me to take what would have been a well-deserved break instead? This is what family-centered care means to me. giving my son the life I always dreamed he'd have. As we know, the NICU is merely the prologue, and the skills and confidence I built as a caregiver during our time on the unit has served my family in every follow-up clinic, specialty appointment, early intervention meeting, therapy visit, committee on special education meeting, and parent-teacher conference and the like. When NICUs implement family-centered care, my family's outcome doesn't become the exception, it becomes the rule. The FCC Taskforce is the first international multi-center collaborative initiative solely focused on family-centered care in the NICU. We exist to support NICUs as they begin or strengthen FCC in their units. I want to emphasize that it supports family caregivers as active, engaged team members throughout their NICU journey, and I invite you to join us in this most important work. As we move on to task force leadership, I'd like to acknowledge that our organization is led in equal partnership between healthcare professionals and family partners, which is one of our key strengths. Our core leadership team is comprised of Malathi Balasundaram and Colby Day, who are practicing neonatologists, and Kira Sorrells, founder and executive director of the NICU Parent Network, and myself as former NICU parents. We have 19 family partners or former NICU parents in our executive council. We are diverse in our infants' gestational ages and diagnoses, and we represent birthing and non-birthing parents and bereaved parents, representing local NICUs, statewide quality collaboratives, and national and international organizations. We have 19 multidisciplinary healthcare partners volunteering on our executive council as well, and we appreciate their time and support. It's rare to witness such authentic collaboration between the various disciplines of practice, such as nursing, physicians, therapists, social workers in our executive council, and we appreciate that they embody our key strength of equal partnership between all healthcare professionals and family partners. This work wouldn't be possible without our esteemed organizational partnerships. We appreciate relying on them to share all of our upcoming events, office hours sessions, and newsletters, and appreciate the opportunity to spread the word about FCC events and achievements in their work as well. It's incredible to see so many parent-led organizations alongside medical associations, and the diversity of these partnerships is part of what makes the FCC Task Force so special. I'm excited to share that we've got almost 2,500 members from every U.S. state except for Wyoming, and 8 of 10 Canadian provinces, and from 70 countries around the world. Our membership grows by roughly 100 individuals each month and truly represents the global reach of our work. We follow the all-in meeting guidelines in all of our meetings. Most importantly, we used first names to address one another to break down the hierarchy that exists in healthcare and empower everyone to contribute. All of our committees are led by one family partner and one healthcare partner on our executive council. Our advocacy committee is currently working to create a comprehensive toolkit for implementing the 13 recommendations uncovered by the present study to support the continuous parental presence in the NICU, even in the face of a respiratory pathogen outbreak like COVID-19. Jesse and Mia are creating a position paper to show our community where the Family-Centered Care Task Force stands on the importance of equity, diversity, inclusion, and belonging in the NICU. They plan to create guidelines around ensuring nonverbal messaging in the NICU is consistent with family-centered care values and bring an equity, diversity, inclusion, and belonging lens to our work to ensure it's reflective of our commitment to health equity. Daphna and Alex are busy sharing FCC Task Force related events, resources, advocacy opportunities, and education on our social media platforms. Please take a moment to follow us. Our domains are also linked on the homepage and footer of our website, as well as at the bottom of email correspondence. The newsletter committee utilizes diverse perspectives in our authorship and releases quarterly publications with actionable and practical takeaways for implementing FCC, including in the areas of communication, discharge readiness, and trauma-informed care. I'll drop a link for our latest publication in the chat and invite you to share it with your network and colleagues. Each month, we offer our members free office hour sessions, which are an informal opportunity for units to bring their specific barriers and challenges to implementing FCC practices to task force leadership and fellow members to brainstorm solutions for overcoming them. These are facilitated by a healthcare professional and family partner from our executive council and are always well attended and full of pearls of wisdom. We've presented 21 free educational webinars with more planned for 2025 and 2026. Some of our most recent webinars include presentations on cultivating compassion, coaching parents and staff towards self-actualization, removing barriers to safer kangaroo care, engagement of families in statewide quality improvement initiatives, and leveraging human connection to care with intention. Our speaker lineup is truly incredible and always includes at least one family voice. I'd like to share a clip of our task force created highlighting families' experience of FCC.
I came into my preemie experience already having gone through the trauma of infertility and already having that, at first I thought it was guilt, but it was shame. It was, I am not a good mother. I can't even get pregnant, first of all. Now I can't stay pregnant. Now I don't know my babies.
The trauma, it begins at delivery and then it just continues throughout until you get to discharge, and then you're processing.
As NICU providers, to take on all that emotion by someone, you'll just be fried by the end of the day, right? But leaving it absent and not addressing it doesn't allow for very good family-centered care. And I think a lot of it relies on communication.
Personally, after I gave birth at 24 weeks, I felt such guilt that I failed the boys, that I was like, now they're in the NICU, they're where they belong, they're with the people who know how to treat them, and they don't need me. I was lucky enough to be in a hospital that had a very strong family-centered care plan, who, before I could even verbalize that, said to me, you're going to change diapers, you're going to take the temperature, you're going to feed them, you're going to hold them, they need you. And I needed that to know that, I was supposed to be there.
After that first month, one of the nurses said, she said, have you held Avery today? And I haven't held Avery ever. And she said, oh, well, we're just going to make that happen today. And I was like, oh, I don't know if I can do that. But she said, we can do it. We're going to do it together.
Simply asking how my day was, or having a conversation with me that has nothing to do with the NICU or babies or monitors or beeping meant the world to me.
In any kind of an ICU situation, your relationship with your partner is at its most fragile, because you're both going through the hardest time of your life together with your child that you both love more than anything.
And I think another concrete thing that's super important that often gets left out, that our family experience, is not having adequate discharge planning. You go from having this like super high intensity experience to sometimes going home from having had a one-on-one nurse alone with your child, just saying like, hey, it's a big change to go home. If you have questions, this is where you call. You're going to have questions. That's okay. You know how to do this, and it's scary. So I think, just kind of naming that for families and helping people understand that you can be a good parent and be scared.
For NICU parents, this is again a life-altering fact, that in the NICU, we are there because we have to, because that's our kid. We are resilient not because we want to, but because we have to. At the end of the day, as NICU providers and NICU teams that could go home, you could change jobs, you could do whatever you can. And again, not to say you don't care, because I know you absolutely care about your families and your kiddos. For us, that's our whole life.
Thank you so much for watching that with us. I'm going to go ahead and pass it over to Malathi to finish us out.
Thank you, Morgan. Thank you for sharing your story, Morgan, and being vulnerable in this space, and I appreciate you. And I have watched this clip so many times, and yet I still get so energized every time I listen to it, and it's so powerful. In addition to the large group educational activities, we had a small group QA collaborative work in 2023. And we published our work this year in the Journal of Perinatology. I will briefly review it in the next few slides. For an in-depth review, please review our paper, and which Morgan will share it in the chat. Next slide. So we have created smart aims to increase the percentage NICUs with the Family Centered Care Committee and also the Family Advisory Council by 10% within a year time period. I will be using a Family Advisory Council and Family Partnership Council interchangeably. Some centers, they use a Family Advisory Council and some use a Family Partnership. Personally, I prefer Family Partnership Council so that they can actively partner with us rather than being a passive advisory role. And next slide. So we focused on creating a committee with the belief that a strong local team and FCC champions would improve FCC practices. We explored barriers and found that integrating with former NICU families through committees can help us overcome many of them. Next slide. So we had a total of 22 NICUs divided into 5 small groups, and we grouped them based on their levels of care and met monthly, led by both neonatologists and family partners. And FCC champions from each center completed surveys 3 times during the study period. Next slide. So this slide displays the Pareto charts. If you are in QI, you're already familiar with the Pareto chart, illustrating the top barriers to form the FCC committees and Family Partnership Council. We have noticed a lack of staff time and need for culture change, and families unable to come to the NICU are the top 3 barriers for FCC committee formation. Next slide. So based on the identified barriers, we created a key driver diagram and change ideas to improve our goals, which we shared with the teams to modify based on their local units' needs. Next slide. So as Morgan mentioned earlier about our educational webinars, we track the webinar views as a process measure, which the webinars helped create awareness and change the culture, and showed improvement from average of 28 views to 182 views during the study period. Next slide. So we showed improvement in our outcome measures from 18% to 59% in forming the Family Centered Care Committee, and 18 to 45% with forming the Family Advisory Council. Next slide. So the conclusion of this study is within a year, 16 out of 22 centers are able to form FCC committees and began meeting regularly to improve their FCC practices. And 15 out of 22 centers formed a Family Partnership Council. Next slide. I want to acknowledge the small group leaders and QI mentors and 22 centers, FCC champions, and the funder for this work. As you can see, we had 2 neonatologists and 1 family partners in each small group, and I was lucky to have 2 family partners in my group. Next slide. So I asked Morgan to add a video clip or quote to the transition slide before I discuss the data-driven next phase of our work. She added this image, and truly, this is one of the many reasons why I do what I do. I built this coalition without any protected time or support during its first 2 years of inception. As you can see in this image, the complex nature of the family trauma while they are in the NICU. So FCC is a must, and it should be a standard of care. So beneath the challenges and frustrations of healthcare, I know the work we do changes lives. It's supportive, pivotal, and powerful. Next slide. So during our executive council meeting, we discussed how to determine whether we are truly delivering family-centered care. There are no FCC measures in place to benchmark the FCC performance among NICUs. So we asked family partners what was important to them. We collaborated with healthcare partners in our executive council and FCC experts and developed an FCC measure survey in 2024. Focusing on 7 domains, which are listed in the slide. So we have received partial support from Casey Educational Grant to create this survey. Next slide. It's not just our organization that believes in this project. In June 2024, Stanford Impact Labs awarded the FCC Taskforce a Stage 1 seed partnership to support our work in optimizing the delivery of family-centered care in the NICU. With the help of Stanford Impact Labs and in collaboration with the NICU Parent Network, we are exploring FCC practices on a scale that exceeds prior studies. Last October, members of our research team attended a Stanford Impact Lab Pathway to Social Impact workshop. It was an incredible opportunity to collaborate in person. Next slide. This slide shows the expanded examples of each domain and what questions were included. Each question had a score assigned, so participants received scores in each domain based on their response. We distributed the survey to NICU clinical leaders globally through the FCC Taskforce and asked them to collaborate with their teams to complete this comprehensive survey. Next slide. So this table shows the demographic data of the 99 centers. We had a little over 50% of NICUs were level 3, which is community NICUs, and 38% level 4 children's hospital. And the rest are level 2 low acuity NICUs. 1/4 of participating NICUs had a 40 to 60 bed capacity, and 1/3 had a 250 to 500 admissions per year. And 84 NICUs from the US completed the survey. The rest are from global. Next slide. I will be sharing the box plot results based on the AAP levels of care as well as the NICU admissions per year. As you can see, the x-axis is lifting, so AAP levels of care. So this is level 4 is children's hospital, level 3 is community NICUs, level 2 is a low acuity NICUs. And the NICU admissions, we split them into less than 500 admissions per year and more than 500 admissions per year. So we looked at this in a total score, like how they differ. So as you can see, the centers have a higher levels of care and a higher admissions had a higher total score. Next slide. When we looked at each domain level, we noticed similar findings that a higher level of care and a higher NICU admissions, you had higher scores in the NICU framework. So just to recall, NICU framework is like, do you have a lactation support? Do you have social worker? Do you have a family-centered care committee and family advisory council? All are included in this NICU framework question. Next slide. So we noticed the similar in family support. This section focuses on their peer support and discharge education, what kind of support system they in place for after discharge. So all those things fall in this category. And we noticed a similar finding. If you have a higher level of care and a higher the NICU admission, and you have a better score in this section. Next slide. Same goes with the NICU family environment. So here we ask them, do you have a furniture to support the families to have a skin-to-skin care? Do you allow them to be rooming with the babies before discharge? So this also goes with this. If you have enough support system and resources, then you have a better environment to support the families. Next slide. So we asked them, do you integrate families into QI work and do you train them to become part of the QI work? And we found the same thing. So if you're a higher level of NICUs and a higher admission, then you have a higher score. Next slide. The other domains, we didn't notice any difference. In the family integration into care, it didn't change. There is no difference between the levels of care or the NICU admissions per year. So as you can recall, this is one of the core components of family-centered care, encouraging them to be part of the team and participation. So that's we are not doing well. The next slide. And then staff education. So it goes along with that too. So if you have a higher level of care, it doesn't mean you are providing a better staff education about the family-centered care or trauma-informed care. So that's what we noticed in this study. And actually we closed this survey last week. And so it's just, we are getting this preliminary data. So we are going to analyze in depth soon. Next slide. In conclusion, the higher the NICU admissions per year associated with the higher scores in all domains. And if you're higher the AAP levels of care, you have a higher score in NICU framework, family support, and NICU family environment, NICU family integration into quality improvement, but not in other domains. So next slide. So my hypothesis is like, okay, there's no structure or standardized day in place for the staff education about family-centered care or trauma-informed care or effective communication. So that brings us to our next step. So our research study is a mixed method study that combines both quantitative and qualitative interview. So we have scheduled 41 interviews so far and completed 31. Using that data, there will be an opportunity for NICUs to collaborate in a small group setting to implement site-specific or topic-specific quality improvement work. We are also focusing on creating a staff education curriculum for NICU staff to focusing on trauma-informed care. I'm happy to come back and share our progress next year and where we are with this final analysis and the next stage of our work. The next slide. I sincerely thank my research team for their dedication to this critical work and Stanford Impact Labs for their funding support. I'm happy to answer any questions that you might have, and thank you for allowing us to be here and share our passion. Thank you.
Thank you so much to you both for sharing your stories and sharing about this task force and your research. If anyone has questions, please feel free to hop off mute. Yes, applause. I know it's always awkward on Zoom, but applause to both of you. We appreciate you so much. If you have a question, please hop off mute and ask it. I see a few people might be
Yeah,
off.
hi. My name is Gauri Madhavan. I don't have a question. I just have a comment. I just wanted to thank Dr. Balasundaram and Morgan. Again, I'm very passionate about your work, and I just wanted to share with the audience that we manage the clinical registry program at the Packard site, and we've just been so privileged to have an opportunity to partner and collaborate with Dr. Balasundaram and Morgan for their work. And recently, Dr. Balasundaram was kind enough with Morgan to come and share at our registry learning collaborative, which is again for the hospital audience. So again, this work is very passionate. So thank you again. This is so impressive. I was off camera because it was so hard to hold the tears back. Again, tears of joy. So it was amazing. Thank you again.
Thank you.
Thank you.
Thank you so much.
Thank you, Gauri.
This is a very impressive group. I'm Liz. I'm the Executive Director of Patient Experience at Stanford Medicine Children's Health. And my question is really about, how does this work trickle down to our own patients? We have a Department of Family-Centered Care and a NICU advisory group here in our NICU. How does that all align, and how does the work, trickle down to our patients and families?
Yeah. I think I met with Karen Wayman. So she used to be a family director of, I don't know exact her role, what's her role. And then I have been in contact with the your family advisory council at Packard and then a medical director. So they actually filled out the survey. So we are looking at this, where we are and where we need to go on. So I think the area for improvement, and they are going to meet with us and then interview, so we can go through the survey questions and then how we can support our families. So this is actually, we can compare them too. So how our other level 4 NICUs are doing and where we are. So that's the beauty of this data. So there is no way in the past that we can measure and compare and benchmark. So de-identify the data and then just to separate them level 3 and level 4 and then see where we fit in each domain and then where we have to move forwards. So I'm in collaboration with the medical directors and the team at Packard, so we can just work on improving for our families. Yes.
That's wonderful. If you all need support with experience improvement, you know where to find me.
Yeah, okay, thank you.
I'm excited to see that data.
Thank you for that question. I have a question related to the differences between the level 4 versus level 2 or 3. I'm familiar with the NICUs as like a patient, but in terms of like the operational side, are there different levels of staffing between the level 4 versus the level 3 or 2 that could have just different approaches to integrating families into care?
Yeah, because I think that level 4 for everyone, which is level 4 is the Children's Hospital and referral centers, and they do ECMO and surgery and cardiac and all critically ill babies. They come with level 4, and level 3 is the community NICUs. It depends on the level 3A, level 3B. So you can have some community NICUs, they do the surgery, some they don't do the surgery, some they cooling, and some they don't do it. So it depends on where you are. Yes, the staffing also it's different because you do have like a little bit of more critically, but still all are trained to take care of the NICU babies. And so you can rotate through level 4 and level 3, and you can get it's more with the number of patients, the number of how you come in contact with. That's the only difference, but they can go through the similar training. And community NICUs, you get a feeling of like it's family oriented, and then you have a 3:1 ratio, the staffing. So it is not easy way of like including the families. That's what we are hearing from the staff. So I have a 3 baby assignment, and how do I encourage that family involvement? But in the early phase, it is going to be difficult and complex and challenging. I understand it. But once you get that going, at the end, when the babies are ready to be discharged, they are going to be more competent and confident. Then your job is going to be have less work on your end. So that's the education we have to tell them. Yes, it is earlier. It is going to be a little bit of challenging to educate and guide them and mentor them. But after that, it's going to help you overall. And your question of staff training, and it's just more if you are specialized, let's say if you are ECMO, you needed to have a little bit of additional training, or if you are taking care of the babies with the dialysis, then you have to go the additional training. But overall, the basic NICU training, the staff that go through everything is similar. If anybody here with the nursing leaders, please correct me or just to share your perspective.
Well, feel free to hop off mute when you're ready, anyone from our nursing team. But Craig, do you have a question?
Yes. First of all, I admire and I applaud your effort to better understand the nature and the factors that are driving the spread of your model. I would just make one suggestion that you think about the work of Damon Santola at the University of Pennsylvania, who studied similar spread of behavior change in healthcare and relating the speed of spread and the depth of spread to the organizational network or the topography of the network that exists between organizations. So, for example, your high acuity hospitals may well have an underlying network of other connections. And it's that topography of the network that affects the spread and speed of change. And the insight that Santola and others have been utilized in terms of trying to understand the most rapid way of introducing behavior change in organizations that are otherwise disparate. And I'd recommend you think about that framework, that is, that you're approaching organizations that have an underlying network of relations and familiarity, and then use certain principles of what are the most rapid ways in which behavior change is adopted. But thank you for your work.
Yeah. Thank you for sharing that. Would you mind just putting that information in the chat so I can have the correct spelling when I'm going through that
Sure.
framework? Thank you so much. Appreciate that comment.
Thank you, Craig. Any other questions for the audience? Okay, while you're thinking of them, I have a question for you, Morgan. As a patient and family representative, what have been like the lowest hanging fruits that healthcare systems, hospitals can can address to really make strides on patient and family-centered care?
Thank you so much. I think that's a great question, Sam. I think that the lowest hanging fruit is one that is free and easy to implement. And that is just being relational with patients and families of patients. So calling them by their first or preferred name, introducing yourself, and, engaging with that person on a first name basis. Something that I immediately comes to mind is, when I was impatient with my son, a lot of folks just called me mom. And, you heard I was in the NICU for 117 days. So I'm not asking you to remember my name, but it would have been lovely for the folks that I was seeing every day for 4 months to at least have it pinned at the top of my son's chart, or, a sign at the bedside that said that my name was Morgan. Because I think if we really want to partner with families and we really want to partner with our patients to provide the best possible care outcomes, a really easy, simple way to do that is just by using people's names. I think that it really helps with relationship building, and we know that when relationships are positively built, that translates to trust and trust in the care plan. And I think that we don't refer to each other as nurse or doctor, right? We learn the name of the resident who's, rounding with us for 4 weeks for their 4-week rotation. And so, we should be referring to our patients and their families by their names as well.
Yeah, I echo that, whatever Morgan said. You don't have to have I know that's the first questions I asked. Like, I don't have any financial support and do anything. Like, whatever you are trying to do, I don't have money. I don't have anything, resources here. But simple thing like, okay, connecting with the families, like asking them, going by the first name basis, and then just taking a second to look at their name. You're not going to remember like 100-bed unit, you're not going to remember everyone's name, but at least taking that extra second to look at their chart and then going by the first name and then saying, hey, Morgan, how do you feel about it? And what is going on with Tommy? And what do you, just asking them and including them in the conversation. That's what true family-centered care. You don't need to have like a set up everything for you and fancy room and fancy single room and then having a view and all those. They're not asking all those things. So the simple human to human connection.
Thank you.
That's so powerful, and something, yeah, like you said, like we don't need tons of money to do and to implement that. It should be a small change in care. We have about 1 minute left, so everyone has enough time to transition to your next meeting. Are there any remaining questions in the audience?
I did include Malathi and I's contact information up at the top of the chat. Feel free to reach out if something comes up, later in the day or throughout the week, and we'd be happy to answer as best we can.
And if you wanted to model this into different unit, like we are focusing on NICU. So if you have any other specialty anywhere else, if you wanted to build this, and reach out to us. I am learning too, so we each learn. So that's the way we are building this.
Well, thank you. And yes, we will make sure the SMCI also saves your contact information. So if you lose the audience or can't find it when you want to reach out, please reach out to SMCI and we can help you get it. Awesome. Well, thank you both. And thank you to everyone who attended today. Our next session is in 2 weeks at the same time. I forget who's presenting, I'm sorry, but it will always be a great talk. And again, one more applause for our speakers today.
Thank you, everyone.
Thank you. And slides and recording will be posted soon on our website.
Thank you.
Thanks again.
Bye.